Hello everyone. On behalf of the DBT Welcome Trust India Alliance, KHSTI, IRB and Nature India, I would like to welcome you to this webinar on COVID-19. Thank you for joining us this Friday afternoon. I hope all of you are doing well and taking good care of yourself and your loved ones and your community. Now, as we sail through this COVID-19 pandemic, we all would acknowledge the speed with which things are progressing, including research on COVID-19. The onslaught of information, numbers, graphs, predictions, and whatnot has informed as well as overwhelmed many of us. In such times, what better than having experts answer your questions that keep you up at night? It is with this view that we bring you this webinar where we discuss how science has been moving so far in this pandemic and where do we see things going. Thank you for sending in your questions to the panelists. The webinar is 60 minutes long and we'll try to take as many questions as we can. We would request you to ask questions which are related to today's topics, which are research progress on COVID-19 and future course of the pandemic. So before we begin, webinar will be recorded and shared widely. You can submit your questions anytime in the question box that you see on the console on the right-hand side. Panelists are providing their views on the current situation only as scientific experts and are not speaking on behalf of their organizations or the government. So the speakers we have with us are Dr. Shahid Jamil, Dr. Gagandeep Kang, and Dr. Jacob John. They don't need much introduction, but I would still go ahead and speak a little about them. Dr. Shahid Jamil is the CEO at DBT Welcome Trust India Alliance. He is a virologist known for his research on hepatitis E virus. He's the fellow of all three Indian Science Academies, that is the National Academy of Sciences, Indian Academy of Sciences, and Indian National Science Academy. Dr. Gagandeep Kang is the Executive Director at the Translational Health Science and Technology Institute, Faridabad. She is a medical scientist and is a key contributor to the understanding of diarrheal diseases, rotavirus epidemiology, and vaccinology in India. Last year, she became the first woman working in India to be elected to the Royal Society of UK. She also chairs the National Technical Advisory Group for Immunization and is the Vice Chair for the Coalition of Epidemic, Preparedness and Innovations. Our third speaker today is Dr. Jacob John, who's an epidemiologist and a professor at Christian Medical College, CMC Vellore. He teaches infectious disease epidemiology and quantitative epidemiology. His research and public health focus have been in the area of vaccine-preventable pediatric infectious diseases, and he's worked on the epidemiology and control of polio, hepatitis B, Haemophilus influenza B, and rotavirus. He currently leads a network of clinical researchers estimating the burden of enteric fever in India. So, we start the webinar now, and again, you can type in your questions in the question box on the right. We'll try to take them as we move forward in the webinar. Now, before I start with the audience questions, a question that I have for all three of you, especially Dr. Kang and Dr. Jamil, since you were the maiden speakers when we started with this series about over a month ago. What do we learn from the way this pandemic is progressing? What are the learnings that you would say are important and we've derived from how this is progressing so far? So you decide the sequence yourselves.
Well, ladies first, Shahid. So I'm going ahead.
Yeah.
So I think among the things that we've learned in the last month, there's been a lot of advancement that has happened in the recognition of the illness as well as in the science that informs our understanding of disease and of potential interventions. If you look at recognition of illness, when we first started out, we thought that this was fever and cough. This would result in an interstitial pneumonia. And most of the symptoms were respiratory. That made sense because we knew that the virus bound to a receptor that was expressed on pneumocytes. We now know that that receptor is very widely expressed on many cells in the body, This includes endothelial cells, the gut, and potentially even other organs as well. And some of what we are seeing in terms of disease is paralleling the distribution of that receptor. We are seeing a lot of neurological symptoms. We are seeing a lot of thromboembolic vascular events. We are seeing symptoms that people are describing, like the loss of the sense of smell, that point to this being something that is not limited to the respiratory tract alone. Similarly, you have patients who come in with stroke, you have patients who appear well at home and then are brought into a facility and you discover that they have an embolism. So our understanding of the clinical picture is changing quite rapidly. The fact that the kidneys are affected, leading to a lot of people needing to be on dialysis, these are all things that have emerged in the last month. So I'll hand off to Shahid here for more about what's been happening on the research front.
Well, a couple of things. First thing I would address is how we have learned over the past few weeks that this is neither like the first edition of SARS that appeared in 2003, nor like the common flu that everyone's been talking about. Its spread is faster than the flu, and it is more than a bad flu. The population mortality rates are estimated to be somewhere in the range of maybe 0.5 to 0.7%, which is definitely an order of magnitude lower than what we are seeing in the case fatality rates. But it's certainly worse than a bad flu. The way it has spread has been an enigma. The first edition of SARS infected about 8,000 people, and the outbreak died down in about 7 or 8 months. In only about 4 months, this one has infected, almost close to 3 million people around the world and caused, hundreds of thousands of deaths. So why has it spread so fast? And now we are beginning to understand that while SARS was, people were not viremic, people were not shedding the virus before symptoms appeared. Here, virus shedding is happening before symptoms even appear. So it's sort of like HIV, when you are infecting others, but you don't know that you're infected yourself. And being an airborne infection, it has really gone around the world at very, very fast speed. What we are also learning is that 2020 is very different from 2003. It's different in terms of technology. An example of that is that while it took about 20 months for the SARS vaccine to come to trials, it has taken only 2 months for the first COVID vaccine to roll out from a company into humans. At this time, there are more than 100 vaccine candidates that are in the pipeline. 6 are already in human trials. So that's the power of technology for you within about a decade and a half. And that gives us immense hope that we will be able to overcome this. But there's also a darker side to technology, and the darker side to technology is the infodemics, the fake news that have spread now, which is much worse than what we saw in 2003. I mean, today there are billions of Twitter and WhatsApp and Facebook users, and any news, any fake news just goes around, the globe. So we have seen things evolve pretty quickly, and there are lessons to be learned. And I'll just end by saying what we have also learned is that while the virus may be very inclusive in the sense that it affects royals and commoners. It doesn't care what your religion is. It doesn't care whether you're rich or poor. The pandemic certainly isn't inclusive. It has hit the poor and vulnerable much harder than it has hit those of us who are privileged. If we are able to sit in the comforts of our homes and still continue to work and learn and contribute, we are privileged. So it has also shown a lot of disparity in society. And I think that is something that has not been addressed too much at the level of scientists. And there's certainly an awakening, and I hope scientists are also going to be addressing that in future. So I'll stop here.
Yeah.
Your turn, Jacob. I think you're on mute.
I can't hear you, Jacob.
Sorry. Can you hear me now?
Yes, yes.
All right.
Yes.
So I think it's been a very interesting 2 months, and like Dr. Jamil said, there's been a lot of information to sift through, but it's true that we are learning a lot. We're learning a lot about how the disease spreads. We're learning that the asymptomatic people have a lot more role to play in this pandemic, but there's still a lot to be learned, and part of the reason is about how much data we have access to. While we have a lot of data accessible, we're not very sure about the quality of the information that's coming out, both from the data perspective as well as from what's being published. Normally it took peer review before data came out into press and we had some kind of credibility to go with. Now we have documents available either on Medium or on different forums in which we get information, even other what we call quasi-science publications. So we have to sift through most of this, and probably these sessions that are being organized are really useful because they help us see some of which the information that's coming out, which might be relevant, some of which may not be as attractive as we think it possibly is. So I think the next couple of weeks are going to be very important for us, and both in terms of learning about the disease and its treatment and its transmission, but also to prepare ourselves to be more equitable about how we handle these problems. So that's my opening comments.
Thank you so much, all of you. So the first question that we have from our audience, Dr. Jamil, since you have already touched upon the spread of SARS-CoV-2 from asymptomatic people, we have a question which says, can you elaborate on how this virus, unlike the related ones like...
Ina, you're echoing. I can't hear you very well.
Okay. Can you hear me better now?
Yes.
So, since you've already touched upon the spread of this virus from asymptomatic people, unlike the previous SARS epidemic, we have a question which says, can you elaborate on how this spread from asymptomatic people occurs, and what are the measures that we have in research and diagnostic space for asymptomatic cases of COVID-19?
Well, as I said earlier, before somebody shows symptoms, there is now very clear evidence that for a few days before that, there virus can be seen in their throat, in their nasopharyngeal space. So they could be spreading the virus by sneezing through droplets directly to others, as well as to surfaces from where others can pick it up. And that has always been a problem for any virus that is being shed before symptoms appear. Most people, even the person who's shedding, doesn't know that they're shedding. And it's extremely difficult to know. And that is why it's important for the best mitigation against that is for all of us to be wearing masks. I may not be showing symptoms today, but I may be in a pre-symptomatic phase. The only way I will prevent the infection from spreading to others if I wear a mask when I'm in public. And of course, for everyone else to observe proper hand hygiene and also to take all the other precautions that are being talked about. So that's about it. I mean, that's beyond that. I can't think of any other way to prevent this.
Okay, so the second part of this question actually focused on what measures we have in research and diagnostic space for this issue
Well,
of asymptomatic people spreading the virus.
right. So the way testing is done, you only test when somebody comes up with symptoms, because the PCR test, which is the confirmatory diagnostic test, is a cumbersome test to do. It's an expensive test to do, and you can't really deploy it on large populations. What you can deploy on large populations are antibody tests. However, antibody tests don't become positive for about 7 to 10 days into symptoms. So for the asymptomatic phase, we really have no diagnostic at this time. It's as simple as that.
So if I can just come in there, well, the only way that we know that there are asymptomatic infections is when contacts are tested. And frequently you will find that contacts will test positive without having symptoms. So we have an estimate of the proportion of contacts that test positive, and then you can follow them up to see what proportion go on to develop symptoms. There are clearly people who do not develop symptoms. So it's been estimated that a large proportion of the infections that people are getting now, they're actually acquiring from asymptomatic individuals. Jacob may have a better sense of the numbers for that.
So this is another space where there's been a lot of conflicting literature about what proportion of population is asymptomatic. The initial estimates were that about 37% would be asymptomatic and the rest would be symptomatic, but that's changing quite dramatically after some of the recent work in Santa Clara and other places, which suggests that there is a lot. When you talk about people who don't have the disease, we're really talking about two groups. One is an asymptomatic infection, and in that is a group that is also pre-symptomatic. So there are some people who will never have the disease or never have symptoms and go through infection. But there are also a group of people who are infected or probably develop symptoms of some form or the other, but are in a pre-symptomatic phase. Both of these groups, unfortunately with SARS-CoV-2, are people who can infect others, which is what Dr. Jamil was saying, different from what we saw with SARS, the first original version of the SARS, where people became infectious really when they became symptomatic or when they had severe disease. There were other differences as well. But going back to the research and diagnostic space for asymptomatic, I think the value of serology, while it is not really to detect and control the problem, it's got huge value in terms of identifying if a lot of people get asymptomatically infected and if they mount an immune response that protects them, then that leads us towards having a population which has better levels of immunity. In addition, if that doesn't happen, if there isn't much of asymptomatic infection, then all of us are still susceptible to get infected. So understanding that from a public health perspective is extremely important, and I think serology will have its role. The antigen-based assays have unfortunately not been good enough at this point to talk about, and hopefully we will get there in a while. But they're really the two tools, like we heard, were RT-PCR and serology being more important for policy rather than for direct management of people at this point.
So the next question is for you, Jacob, where people are asking about the projections on how this disease will progress in the coming weeks, and if doubling time is a good measure to interpret or to assess the spread of infection.
So this is a question that's really been on all our minds. We want to know what is in the future for us. And unfortunately, all models that we have are wrong, but some are useful. And how useful these, essentially all our thoughts and projections in our mind are really models. Just that mathematical models are more structured, that we ascribe certain probabilities to the different events. And for us to be able to do any of that, we need data. And in the early phase of any pandemic, that data is really difficult to get. But we have really got to get our act together in terms of getting information, because only then can we predict really what's going to happen. But fortunately for us, we can learn in today's connected world about what's happening in other countries. Even when we don't have information on the basic reproduction number in India, the outbreaks happened in Japan and then in China and in the ship.
So let me pick up there, Hina. I think Dr. Jacob John has spoken. He's back. Can you hear?
Based on what we call compartmental models. That's the traditional way of doing it. All models that are being used today. Sorry, can you hear me?
We lost you for
Which
a
are
while.
cadence-based models. But what you were asking me about is also, can you use doubling time? Sorry, my internet is playing up. So we're talking now about using doubling time as a measure to see how the projections are. And that's a good idea in the sense that you can use doubling time to tell how fast the outbreak is going. Sorry if I can't be heard, then I'll just stop here and maybe let Cherry or someone take that question.
No, it's fine.
We can hear you, Jacob, right?
Okay, sorry about that. Somehow there's a problem with my internet here in my office. So what I'm saying is doubling time is a great tool if testing is uniform and testing is probability based, and it's consistent over a period of time, and that then tells you how fast the epidemic is moving. The longer the doubling time, that means the epidemic is coming down. And as we saw recently, people talking about Kerala, the doubling time is 72 days, which means really that we are going towards an R of 1. But that only works when the testing is a uniform way of testing. Either we are testing everyone with the disease, or we are testing a probability-based sample. Unfortunately, in an epidemic, it's difficult to do that. One, because we have shortage of kits. Second, we have strategies which test only contacts, and so on. So there are caveats with it. And if it's only being used to say, are we on the upslope of the epidemic, or are we plateauing, that's fine. But if you're trying to do more about comparing India's trajectory against Italy's trajectory or something like that, that becomes more difficult unless the methods are very similar. Oh.
So, let me also add that, models are all based on assumptions. So any model is only as good as the assumptions you make. And usually early in any outbreak, since data is very limiting, you make a lot of assumptions. So as time goes on, you refine your models. And a lot of that is happening. The other point is that you can't make a general model for an entire country because conditions vary. Just for example, the population density of Delhi or Bombay is very different from the population density of Arunachal Pradesh or the desert area of Rajasthan. The disease is not going to spread at the same rate in these places. So what is going to be more useful in future would be state-specific models, region-specific models, and therefore, as we go on, if decisions are going to be based on data, it would be better to make those decisions locally rather than decisions coming from the top in Delhi, because it may not be relevant to a given location. And that is where I think we lack capacity in the country for intelligent, data-driven decision making at the local level.
So I couldn't agree more with Dr. Jamil about the need for data. The one point I just want to make here is that there are several good models which are now trying to do precisely that. They're waiting for more information to come in. I know that there are groups in India which are doing these agent-based models which precisely take into consideration population density, age structure, and they have models for each state that are ready to run. But the key issue here is we need more information that can actually inform us. And garbage in, you only get models with very little that you can put out. So uncertainties are there, they are decreasing, like Dr. Jamil said. We will get there as soon as data becomes available.
So, Dr. Kang, the next question I would pose to you, this is a favorite amongst people, which is about herd immunity. So they're asking, how long will it take India? How do public health policies strike a balance between
I think the herd
attaining
immunity question, yeah, I think it's best that that's directed to Jacob. Okay, since Jacob can't answer that, Jacob, can you speak?
Yes, I can now. Yeah.
Go ahead.
So what? I couldn't hear the question. Can you repeat that again, Hina? Sorry.
Question one was
so
on
the
herd
question,
immunity.
Okay. So the idea behind herd immunity is that as the population gets a larger and larger proportion of the population move from a susceptible to an immune group, they tend to afford some kind of protection to those who are not yet infected and who are still susceptible. So herd immunity is a fundamental concept of all infectious diseases, especially when you talk about things that are contagious, that are contact based, that is spread from one individual to the other. It doesn't apply so much for infections which are probably waterborne or one of the other mechanisms. They may apply there, but not so much as in a case like SARS-CoV-2. So what happens is, as the population reaches a certain level of immunity, the transmission of a disease depends on three parameters actually. It depends on probability of transmitting an infection to a susceptible person, and the number of contacts that you have with susceptible people, and the duration of contact. So if the transmission probability of the organism is related really to the characteristics of the organisms and characteristics of the host, the person who's getting infected. But the contact probabilities start decreasing as people become non-susceptible. When they no longer can transmit the disease, they create a barrier. And I think this will be critical for us if we have to have immunity against SARS-CoV. Some of this herd effect can also be generated through vaccination. So there are these two concepts, but the herd immunity is generally the idea that the population which is susceptible is protected by people who have already become immune in the past. And it's the relationship is usually like it's 1 minus 1 by R0. Sorry about the formulae, but basically to say it's about 60% of the population needs to be infected before you can really think of breaking transmission to a level at which the epidemic is no longer active. We might get sporadic cases, but it will no longer be an epidemic once you reach that threshold.
So since we're talking about the immune response to the virus, my next question is to Dr. Kang and Dr. Jamil. Somebody is asking, what do we know about the immune response in other animals or mammals to this virus, and how is this information going to help the development of vaccines or therapeutics?
Sure. So if you look at the virus, all viruses induce an immune response. Whether that response is protective or not is something that needs to be determined. In the case of coronaviruses, we know from seasonal coronaviruses that the antibody response that is made tends to be quite short-lived. Of the 4 seasonal coronaviruses that regularly infect humans, there appears to be a short-term protection of a few months, and then you become susceptible again. Now, usually this doesn't matter because the infection that seasonal coronaviruses cause is the common cold. In the case of MERS and SARS, which are the 2 other coronaviruses that we knew before this, there is an antibody response that is made, and that antibody response can be measured. There's also not just an antibody response that shows binding of the antibody to an antigen that is on the virus, but also some level of functionality. And functional antibodies or functional immune responses are measured in viruses, mostly by neutralization. And the neutralization means that if you have an antibody, it binds the virus and it stops the virus from infecting cells. That means the virus can't get in and the virus can't replicate. And this can be measured in the laboratory. For many viruses, we know that this functional antibody measurement through neutralization is actually a correlate of protection. So for example, for polioviruses, if your serum diluted 1 in 8 neutralizes the virus, then you know that that person is never going to develop polio. Now for SARS and for MERS, we know that neutralizing antibody responses are made and that they last for a few years. They at least 2 to 3 years for sure. In the case of SARS, in some people, neutralizing antibody responses were measured for longer than that. In the case of SARS coronavirus 2, we know that antibodies are made. We know that neutralizing antibodies are made. These are assays that have recently been established. And we're finding that people who have severe disease tend to have a stronger immune response than people who are asymptomatic. There are studies that have been done in animal models. One of the most urgent things was to try and establish good animal models once the virus was discovered. And there was a lot of learning from SARS that was applied here. What we found was that people thought that ferrets would be a good model, but it turns out that hamsters are a better model than ferrets, because in ferrets you only get an upper respiratory infection, whereas with hamsters you get both an upper and a lower respiratory infection. So it resembles more closely what you see with the clinical situation for SARS coronavirus 2. There are also specific animal models that have been developed, transgenic mice that express the receptor ACE2. Those are available in very small numbers at the moment, and they don't really reflect the immune response as much. If we look at the application of these studies in animals to what it means for vaccines, we've recently had some very exciting news, which is that the Chadox vaccine, the chimp adenovirus vaccine made in Oxford, when given to 6 monkeys in the US, when these monkeys were given the vaccine and after a while they were challenged with the virus, none of the monkeys got infected. And that means that we have data from a closely related cousin, primates, to show that if you are given a vaccine and you make a good immune response, that appears to protect you against infection. Now, whether this will hold in humans, we don't know for sure because we haven't got that information yet. But chances are that this will be the case. And if it is, and this protective immune response is induced by the ChAdOx1 vaccine, we should potentially be able to advance vaccine development much faster. Another way of doing it, which other people are thinking about, is to do similar challenge studies in hamsters, and that might yield good information as well, because primate experiments are difficult and extremely expensive to do. And even though 6 primates sounds promising, no vaccine is going to be licensed on the basis of 6 monkeys.
Well, I think Cherry has said everything that needed to be said. I'll just add one point, and that is about the innate immune response. So besides the adaptive response, the first line of defense is the innate response, and how that is able to control the virus early on decides the future course of action. People who die of coronavirus disease have also shown that there is a hyperactive immune response, something called the cytokine storm, that includes a lot of inflammation, a lot of accumulation of pus in the lung, which is generated by the host fighting the disease. And it's very curious that bats, which are also mammals that harbor many of these viruses, never really show disease from this virus. And data which is now coming out suggests that bats don't get that hyperactivation, that cytokine storm which is seen in humans. So we have much to learn about various aspects of the immune response, and this virus provides a nice tool to understand that as well.
Dr. Jamil, in line with this, we also have a question from many people which says, what data do we have on the mutations in this virus and how will it affect the development of vaccines or their efficacy or how we diagnose the disease?
Well, by now there are close to 5,000 virus sequences that are in public databases. And what it shows simply is that the virus is evolving. The virus is changing, but it's not changing enough to become a different virus. I mean, there are very confusing terms that are being used. So, people are talking about different strains of the virus. These are not different strains of the virus. These are different clades, different groups of viruses. So just to give you an example from HIV, for example, HIV has 2 types of viruses, HIV-1 and HIV-2. Those are different strains of HIV. Within HIV-1, there are 9 different groups or clades. So it depends on how much a virus has evolved from the parental strain to be called a separate strain. There is no evidence so far that we have multiple strains circulating around. We have multiple groups circulating around. And the mutation one sees is not enough to suspect at this time that diagnostic tests won't work or a vaccine won't work. It's not like flu where an antigen completely changes sometimes, but that flu is a very different virus, very different composition of the virus. So at this point, I don't think there is compelling data that this virus has evolved enough to be a worry for vaccines or diagnostics.
I come to you, Jacob, next. A question which is again a pertinent one is, what are the possible reasons behind low percentage increase and lower number of deaths in India compared to the West or other countries?
Um, so that's a good question. What is part of that? I think of 3 points at least. So the first one is we went into a lockdown pretty early in an outbreak. So that's a good thing about we have decreased the contact between individuals, and that might have had an impact. And that's the biologically plausible bit. But I think more importantly, what we are really seeing is just a tip of the iceberg. We are later in the epidemic than most other countries. Our testing algorithms have been very restrictive, to say the least. We were testing contact cases and their contacts, and India is a very large country. Proportionate to the rest of the world, we've been testing very little, and we've only been testing if you've had history of contact with a case for a very long time. More recently, we started testing SARIs, but if you look at the data that's coming out, we don't see enough of the severe acute respiratory infections being tested. So overall, I'd say that we aren't testing enough, so you're not seeing much of the disease. Now, the argument about deaths, you've seen this in the BBC and in other places, that there are several groups saying there aren't deaths. But deaths, and something about SARS-CoV-2 that's confounded a lot of people, is that the deaths come much later after infection than we earlier anticipated. It's not like you pick up the infection now and you start seeing a peak of deaths. So deaths will come. And I think we're too early in this game to talk about how many deaths are going to be there or how many cases. We are pretty early in an outbreak. We've done some things well, such as being able to decrease contacts. But having said that, decreasing contacts bought us time. It's not changed the entire story yet. So the story is going to play out over a few months, and that's what we will see. Hopefully, there are things that might work in our favor. One is the extremely high temperatures. We don't know what it will do, but we hope that humidity and the high temperatures will have some bearing, but there's no evidence yet to suggest that that's going to happen. However, in India, again, about deaths in particular, about 60 to 70% of deaths happen outside of a facility that can actually test or diagnose accurately. So going by what we see today is not a great idea of what's going to happen in the future.
While we talk of testing, Dr. Kang, there are people asking, how would you compare RT-PCR versus antibody or antigen testing in terms of scalability, and what are the limitations of developing a rapid detection kit using saliva?
Sure. So if you look at RT-PCR, it's essentially detecting the presence of the virus. It may be virus capable of replication or not capable of replication, but you're looking for the nucleic acid inside the virus. And basically, the genome of the virus is a long string of RNA, which is wrapped in a ball of protein. So you can either look for the RNA or you can look for the protein. RT-PCR or all nucleic acid amplification technologies look for the RNA. And if you have an antigen test, that is looking for the protein. An antigen test would be extremely useful because most of the formats that are used for antigen detection are ones that are easily available in many parts of the country. These can include ELISA formats that many laboratories are familiar with, because a lot of our HIV testing is done as HIV, hepatitis B are very widely done as ELISAs. You could also do the antigen testing in a variety of different ways. You could have approaches that are aptamers, which is short strings of nucleic acids that can bind to various components. You can have approaches that make it into a really rapid test, which are the lateral flow formats, which is not quite like a dipstick, but you put a drop of your sample on a piece of paper and then it wicks up to give you a signal that is detected as lines on the paper. So these kinds of lateral flow formats have already been adapted for the identification of antibodies. IgM, which comes up first in infection, and then IgG. These are also the rapid tests that have just been withdrawn from India because of their poor performance. But for every test that you have to recognize the uses of that test as well as its limitations. So RT-PCR is a very, very sensitive test. It detects really tiny amounts of the virus, but it is, people say that the sensitivity of RT-PCR is 70%, but when they say 70%, that means that out of 100 infected people, at the time that you test them, you will get only 70 RT-PCRs positive. So how is that sensitive? Well, it's because a lot of the problems with the tests come in how samples are collected for the tests. If you don't do a good collection of a nasopharyngeal swab, and it's not simple to do one, or a deep oropharyngeal swab, then your test is going to be a false negative. So RT-PCRs need to be well done to be sensitive. They are also very specific tests that you don't usually get false positives on an RT-PCR. Now, for the antibody tests, these tests are tests that measure how you respond to the viral infection. So they don't become positive early in the infection. Your body needs time to recognize that the virus is there and then react to it by making antibodies. So you don't see antibodies till at least a week to 2 weeks after you have the infection. Usually the first antibody you'll see is IgM, and that comes up 7 to 10 days after you start to have symptoms. And the IgG antibody comes up usually in the 3rd week of infection. So by the time the antibodies start coming up, your RT-PCR is going to start to miss cases because there'll be less and less virus there because the body is now handling the infection well. So if you have to do testing in the first week, it has to be RT-PCR or antigen, and from the 2nd week onwards, you can think about antibody tests. But be aware that antibody tests have limitations in that their sensitivity and specificity is not perfect. You can have both false positives as well as false negatives with these tests. So you need to know how to use them.
So another question that we have here, which I would ask both Dr. Kang and Dr. Jameel, is that, so why are we talking so much about vaccines and probably not enough about drugs? And what's your take on repurposing of drugs? What's the current evidence? Where are we?
So if you want a drug for an unknown pathogen, the first thing you will go to is available compounds to see whether there is something already available that you can use against a new target. So repurposing of drugs is your fastest way of having a treatment. And to be able to set up to do repurposing, people run screens with all of the available licensed compounds or known compounds and see whether they have an antiviral effect. It's possible now to do very high levels of screening, first to look for binding and then to look for activity of a drug. And this allows us to shorten the time to identify what potential treatments might look like. So, for example, hydroxychloroquine or ivermectin were both identified on such screens. And one easy way of starting to do a screen is to look at what worked for related viruses. and then think about applying it to the new virus as well. So remdesivir, for example, was being tried for MERS and is now being considered for SARS coronavirus 2. I also noted that I forgot to answer the second part of your last question, which was about using saliva for diagnosis. And absolutely, this is something that needs to be tried. There is data out there that shows that saliva might actually be a very good sample for virus detection. But right now, what we should do is try and do comparisons. So use the existing methods of NPOP swabs and do saliva on the same person and then see whether it works equally well or not. Or if we are missing something, we need to understand the proportion we might miss by going for an easier sampling strategy like saliva. So sorry, distraction from drugs, but important to address.
Oh, Hina, just address the one issue with the saliva testing and then go to drugs. Just finding saliva to be PCR positive is not an indication that the person is transmitting, because the saliva has been found to be positive all the way up to about 30-35 days post symptoms. And when this saliva was taken and used to grow out the virus, people have failed to grow out the virus. So just by having something as PCR positive is not an indication that you have infectious virus. And that's an important point to understand. Every PCR positive sample is not an infectious sample. Coming to drugs, it's not right to say that the focus is entirely on vaccines and not on drugs. At this time, there are close to 70 different potential drugs that are being tested. We have also seen how people have jumped the gun, for example, with hydroxychloroquine. And, needless to say that someone is now stuck with 35 million tablets of hydroxychloroquine and they don't know what to do with it. Perhaps we should send some malaria their way to utilize this. But, jokes apart, we have seen how remdesivir has gone up and down in this whole saga. I just read today that IICT Hyderabad has developed the active pharmaceutical ingredient for the flu medicine Frapavir, which is now being transferred to Cipla to scale it up. So there's a lot of movement, both globally as well as in India, on drugs. And as Gagandeep just said, repurposing of drugs is very, very crucial, because that's the fastest you will respond in a growing outbreak. But with time, we will see more specific drugs, especially since we have a lot of structure-aided drug design now working. People are able to decipher the structure of key enzymes in this virus. Protease has been done, replicase has been done, the spike structure and how the spike gets cleaved has been done. So look at the speed at which things are moving. It all comes back to the point that technology is really aiding us in fighting this disease.
One more treatment that a lot of people are hearing about in news is the convalescent plasma therapy. So could one of you please elaborate on that? How much promise does it hold currently?
This is another one of those where what Shahid was saying about hydroxychloroquine jumping the gun kind of sort of applies, but perhaps we are being a little more cautious here because it's a biological that is coming from patients. There are anecdotal reports that people have done well after convalescent plasma therapy, and there is a need to understand that there are actually two ways to do this. One is to take some convalescent plasma and just put it into a person. The other is to do plasmapheresis, where you take what you need from a person and put the rest back into them. So the ability to treat people, how many people you can do with the two different approaches varies. With just doing a standard plasma donation, it's a smaller number. So there are currently ongoing clinical trials in multiple locations around the world that are evaluating the value of plasma therapy. It has been approved as for use in India by the Drug Controller General of India, and people are being put onto it. The question that I really have about this therapy and how it's being evaluated is, at what point do you want to give somebody plasma? So do you want to give them plasma early or late? My understanding is that in the Indian context, we are requiring that people be on ventilators and really, really sick before you give them plasma, whereas in other countries, the idea is to try and treat people earlier in the illness. When you think rationally about where antibodies are most likely to act, they are most likely to act early in infection. So the point about at which point plasma should be given in the clinical course is something that I think needs a little more discussion when clinical trials are designed and done, or whether when people decide that plasma can be used on the basis of a compassionate use authorization.
So the next question is for Jacob. People are asking why we are not using next generation sequencing yet enough to understand the epidemiology of the virus and for surveillance and containment, even though it's a widely accepted, highly advanced technology. And would the lockdown be enough without enough testing to control the disease in a largely populated country like India?
So maybe I'll take the first part of the question.
Sorry,
I'll
I'm going
the
to pass that question. Yeah.
So if you look at NGS, it's a very powerful technology. There is a lot you can do with it. So in
Yes, Jenny.
terms, yeah, if you take a lot of samples together, you could pool them and apply NGS to it. It would allow you to test a lot of samples really fast and get detailed information on whether the virus is there and then what is the virus. You'll get the sequence as well. Now that makes a lot of sense in theory. It makes less sense in practice when you think about how samples are actually collected from patients, where they are brought to, and where they are tested. So if I need 1,000 samples to be able to do an NGS run, then I'll have to wait till I get 1,000 samples and only then start to use this technology. If I'm only testing 10 samples a day, I might be waiting for many, many, many days before I get enough samples to be able to do such a run. I could do fewer samples, but it doesn't make sense to do NGS for a very limited number of samples. So, as I said, sounds potentially very exciting, sounds potentially very scalable. But I think we need to have a little more thought around the processes by which you will accumulate enough samples to be able to do this. The Institute for Genomics and Integrative Biology has tried this out. They tried with a MinION, which is a really tiny device for doing sequencing, for about 15 samples together just to get the entire sequence of the virus out. It's useful for that kind of approach, but if you were to use it for testing, you would want a much larger number of samples to be tested in order to justify the time and the expense of such a technology. In terms of testing and the lockdown, I will leave that to Jacob.
In terms, okay, thanks, Sherry, on taking that question. The question about testing and lockdown, I think there needs to be an approach which is very similar to what we did in HIV and otherwise, looking at sentinels or places where you would expect to see high amount of disease or an early indicator, canary in the coal mine kind of thing, where you can actually look in populations like frontline workers, like healthcare workers, and see what's happening among them, and see if they give you a signal about when you can either implement some kind of physical distancing measures in greater extent. I wouldn't want to continue lockdown in any case, but if you had to do something about increasing the distancing, those could be dictated by what you see in healthcare workers, for instance. It could also be that you have antibody-based assays rather than, I mean, to help identify when populations can exit lockdowns. So there are several strategies that are being proposed, particularly if you want to do the RT-PCR. There's been this question about, can we use pooled testing, for instance, to see if you can, in random subsets of the population, to see if you can identify areas which have very low burden of disease or incidence of disease. And that's a possibility. The problem is, at this point in time, we're still so early in the outbreak, the prevalence of these conditions are extremely low, and unless the kind of assays that we use, either antibody assays or the RT-PCRs, work really well, that is, the specificity is pretty high, you're going to have a lot of false positives and a lot of noise around the testing results and how you interpret it. But once the epidemic starts taking off, that is when you're about 5, 10, 15% of the population is infected, these tests would be extremely important in controlling the epidemic in such a way that the healthcare system and the infrastructure that we have doesn't get overwhelmed. So at different times in the outbreak, we'll have different strategies that are important. I think that the early phase would be looking at healthcare workers and other frontline workers, also doing periodic serosurveillance studies in the population, which are probability based, and testing high-risk population. Contact tracing and testing to control the epidemic is also important, but that's in very specific locations. Like Dr. Jamil said earlier, India is not one homogeneous area. There are areas where the virus hasn't entered in large parts. There are places, these places are also vulnerable places in terms of healthcare facilities. Those areas probably need much more sensitive system to pick up and stamp out epidemic as far as possible. But you can't do that in the mega cities. You can't do that in the tier 2 cities, because this will spread. And one of the things that you had asked earlier about is, why concentrate on vaccines and not on drugs? While we need to concentrate on both, unless we can deplete the pool of people who are susceptible to disease, this virus will find a way of moving from one to the other till about 60% of the population is infected, unless something happens dramatic. Anything could happen, but I wouldn't put my hopes on that.
So I can see we've crossed the time, which was 3 p.m. If all of you don't mind, can we go on for another 5 minutes so that we can take more questions?
Sure.
Absolutely.
Yeah. So I think I would ask this one to Dr. Jamil. Somebody has asked, is this coronavirus really deadly? Because most of the deaths in the whole world are actually caused by other diseases, and these deaths represent only a fraction of them. Can we call this virus really deadly?
Didn't get the question.
Yeah, so the question is, can we really call the coronavirus deadly? Because we have a lot of other causes for deaths all around the world, and these deaths are only a minute fraction of that.
Sure. I mean, if you compare it to tuberculosis, if you compare it to childhood diarrhea, malnutrition. It's not. But then all those things don't come concentrated within a few weeks. They're spread out. So, and again, the way the virus is moving, it can very quickly overwhelm your, public health systems. So nobody is saying that you focus only on coronavirus, and that's why I differ a bit from the strategy which is being used. That hospitals today are not admitting anyone else. Try getting somebody admitted in a hospital with a common ailment for which people normally go to hospitals. It's a challenge. So when skeptics say that more people are dying because of the lockdown instead of the disease, to some extent that may be true. So again, you have to balance these things. Nobody is saying put all your effort on COVID. COVID is an emergency situation today. Yes, focus on it, but don't let your guard down on other things. I mean, in this lockdown, how many people are missing their TB medicines? What effect would that have? Would the TB bug become more drug resistant because of the lack of attention to it? We don't know that. Those are some real worries. I would worry about those things.
So, here's the final question, which we would want all of you to answer. What are the challenges to doing good experimental or clinical research in India? And probably something that we've learned over the course of the past 1 or 2 months.
So the challenges to the challenges of doing research in India were there before the last 2 months. And I think the only thing that has changed is really logistics in the last couple of months, because it's become very difficult to get reagents, to get people into work, etc. Those kinds of things are balanced by the push to have more indigenous research being done. So there is activity that is trying to promote research, whereas the structures that we have at the moment don't allow us to do the research that we want to be able to do. In India, I think if you think about research in the context of a public health pandemic like this, the one thing that this has shown us very clearly is the lack of data systems, the lack of an ability to access reliable data that gives us a measure of how big the problem is and where the problem is. In all of public health, you start to address problems appropriately only when you understand the scale of the problem. And that allows you to think about what kinds of interventions, what efforts are appropriate. Here we have been, as was discussed earlier in the modeling, been relying largely on data that has not come from India. We've been relying on data and information that has come from outside of India. And that has been the level of sharing that is going on currently around the world is something that is truly unprecedented. And I hope that this will serve as a model for how research is done in the future globally, but also in India.
And yeah, so
Shari's just put that, and Dr. Gagandeep has put that so elegantly, in the sense that I think what's really changed over time is how international community and the community of researchers, even within India, have started using technology and also being able to share data more freely within the research community itself. So from where I stand, where we work with math models and try to do projections, I've seen several groups of people coming together, sharing ideas freely and thinking about things together, and that kind of has helped the community. But what's really been a problem for us is we work on assumptions, and those assumptions need to be substantiated with data. So for instance, today I do not know how many patients are admitted in hospitals with pneumonia in this country. We have ideas, we have systems, but if they really work well, those questions would be answered. Yesterday or day before, there was this preprint out in the UK of 17,000 patients with coronavirus. They have systems ready at this point, which is able to tell you about all their symptoms, and they share that information pretty early. It becomes extremely useful for us in terms of predicting what's going to happen as clinicians and as public health people in looking at what are the risk factors, where could we intervene. So that system, if nothing else comes out, we need to set those up before the next pandemic comes. And trust me, with the amount of chatter that in the zoonotic space, we are going to see more of these coming. So when they do, we need to have systems which permit us to react faster. They are being set up. We need to build on that. And I think that's the point I'd leave with.
So Hina, I will end with a couple of points. The other day I heard somebody say that there are too many recreational virologists at this time. I take that comment positively in the sense that many more people who are not possibly trained as virologists are attempting to solve the challenges, which is good. It's very nice. And as Sherry and Jacob both said, while this outbreak has been challenging, it has thrown up many opportunities. And one opportunity is how openly data is being shared, how openly people are collaborating. And I do hope that this openness and this collaboration will continue even when the pandemic is long gone and forgotten, although it won't be forgotten for a while. The second point is that the flurry of activity that you see in a pandemic is good, but you don't prepare for a battle when you're in a war. You prepare for a battle before you get into a battle. And that is something we need to start addressing at our research systems level, that funding has to be sustained. Funding has to be not directed always towards asking, well, what have you produced? Because the fundamental knowledge that you produce is sometimes a key to solving a problem when you are in a challenging situation like this. So I do hope that we have learned a lesson from this. I do hope that in future we will also deal with health security as a matter of national security, and spend more on research. Don't forget that when it came to an outbreak, who mattered most? It's the doctors, it's the nurses, it's the delivery people, it's the scientists who mattered most. And I hope that lesson is not forgotten once this is over.
On that note, and with all the learnings, I would like to thank all of you, Dr. Kang, Dr. Jameel, and Dr. John, for agreeing to be on this webinar and for taking all this time to clarify so many questions and queries. We are all learning each day, and there's so much more to learn and explore with regards to this disease, and all of your help was very much of help. These webinars would be meaningless without the enthusiasm of our audience, so thanks to all of them. We do hope to hear about your feedback, and we hope you survey form after the webinar ends. We also get our experts to answer your questions put up in an FAQ sheet online, and we regularly update this, so keep an eye out for that. Take good care of yourselves and your loved ones. We are all in this together. Have a safe weekend. Bye.
Thank you.
Thank you.